I'm Dr. James Lee, Provost of the Global Wisdom Academy, and I'm excited to announce to you the launch of our online certificate program, which will be in partnership with Oral Roberts University. This program will be in an online classroom format where up-and-coming young leaders from different denominations and countries can interact with their peers and highly qualified doctors and professors. The program has been structured to enable leaders and ministers from around the world to think creatively about contemporary ministry and the issues facing modern-day leadership with the wisdom of God. We are now looking for the next generation of men and women who are willing to be trained to take the mantle of preaching the gospel of Jesus Christ into the four corners of the world by the power of the Holy Spirit. If you are passionate about this call, contact us on our Wisdom Conference and Wisdom Impact magazine pages on Facebook, Global Missions Eventbrite page, and Wisdom Impact magazine Instagram page. Thank you, and God bless you.
Right. Good evening to our lovely viewers once again. It's always a pleasure to be with you for the time with the doctors. And this evening, it's an honor to have these lovely doctors on board once again. Hello, Professor Jonathan. Good to see you. Hi. I'll just quickly introduce our guest and then we will get started. So I have here Dr. Vincent Bayoma. Dr. Vincent Bayoma is a senior lecturer at the University of Ghana Medical School, and he is a nephrologist. So probably that should, for those of you who know, that should give you a clue or an idea of what we are going to be talking about. And I also have here Dr. Matthew Che. Dr. Matthew Che has been with us once.
He's a professor today.
Oh, is he a professor? Congratulations. So Professor Matthew Che is here with us once again. And Professor Matthew Che is... You're welcome. He's a senior lecturer at the University of Ghana Medical School, once again, and he is a urologist. So he was with us when we were dealing with infertility, I believe. Yeah, he was with us for that one. And we have my co-host, Professor Jonathan Lai. Professor Jonathan Lai is such an amazing person. He does all the background works actually, and he makes it an absolute joy to co-host this program with him. So welcome you all. And Professor Lai, like we always start. Now this platform is actually a Christian platform, and what we usually do is we usually discuss biblical things and we talk about what God is leading us and directing us. So maybe we'll be discussing like how God would want you to lead your home and that sort of thing. But as ministers of God, as I always like to ask Professor Lai, why is it important for us to be discussing these topics? Why is it important for us to be dealing with these medical topics?
So thank you very much. And welcome everyone to today's program. So I think it's very important for us to discuss health-related issues because we live in a body. Much as, as children of God, we are spiritual beings. We live in a body, and the body, as God has said, is the temple of His Holy Spirit. And we need to take care of this body. Just like, when you have a car, you take the car for servicing, you take the car for oil change. Sometimes you need to change the tires of your car when they are worn out. Same with our bodies. And if we don't take good care of our bodies, then we are not going to be in a position to fulfill the mandate that God has called us to be. Because if we are sick and unhealthy, we will not be able to make an impact. Even though we may be called, we may be filled with, the Spirit of God, we may be, we may have a calling upon our lives, But if we are not well, we will not be able to fulfill that mandate to the fullest extent. And so it's really important for us to understand some of these things so that we will apply wisdom. You know, the Bible says, teach us to number our days so we may apply our hearts to wisdom. God has given us wisdom. Jesus said it is the sick who need the doctor. We want to make sure that we actually even don't get sick, that we will live kind of a preventive life, you know, a life of preventive health, so that we will not even get to the point where we need the doctor. But even if we need the doctor, we need to understand how to live our lives and live our lives in a healthy way that pleases God. So I think that's why it's important for us to talk about these things. And for today, you know, we're going to talk about kidney disease. And as Maud said, we have, you know, two distinguished gentlemen who are specialists in the area of kidney disease. And we've already introduced them. So I'll hand over to Maud to proceed.
Thank you so much, Prof. And thank you, viewers, for joining us once again. Now, if you can tell us where you are watching from, that would be amazing. And again, I would like to ask you to share this program with your family. Now, I know there are so many countries where medical care is actually done on cash and carry basis. So you pay money and then you get to see a doctor. You pay money and you get to see a doctor. But guess what? Tonight, you are very privileged. You don't have to pay any money. And you've got these two consultants here with you. And they are going to answer your questions, anything that is bugging your mind with regards to kidney disease, any misconceptions, any hearsays, anything that maybe a friend's family is going through or your family is going through. So just share the link with your friends, share the link with your family, call them to come over and come and watch. We are live on YouTube as well. We are on Facebook and on YouTube. So call your friends over and come and let's learn some great things. I know I'm going to be learning some amazing things. And like Prof. Lai said, the essence of this is that actually maybe we can actually live in such a healthy way that we don't even have to see the doctor. Because look, if you get to hear all this information and all they are trying to do is how to prevent things, how to prevent this, how to prevent it. So if you are actually preventing it, then maybe there would actually be no need to be curing, to be thinking of, okay, it's so bad, what can we do? What can we do? So come over here tonight and come and get wisdom. Come and get wisdom as we talk about kidney disease. Right, so I'm going to start straight away with Dr. Matthew Che. So Dr. Che, we know about the kidney. I remember a few months ago, actually, I was having a conversation with my children and we're talking about the kidney beans. And they said, why is it called the kidney beans? And I said, well, it's because it's shaped as a kidney. And that brought about the whole topic. So what is the kidney? What is the kidney?
Yeah. Well, thank you very much, Maud. I think the kidney is quite an important organ so far as our survival is concerned. As you rightly said, it looks like beans. So there are two bean-shaped organs that are located in the abdomen. They are quite deeper than our normal stomach and intestine. So they are right behind our back. So that when there are challenges with it, sometimes you feel pain, but the pain is more towards the back than towards the front or towards the navel or the umbilicus. So it is lower down there. It is just below the ribs. So that, yes, if you are coughing, we say that probably the kidney is not there. But just below the lungs or the ribs or the diaphragm is the kidney. It's quite a soft structure, so it tends to be protected. So the last three ribs, we normally say that the 10th, the 11th, and the 12th ribs actually protects it. It's encaged in it. And behind is the spine, bone, and then some thick muscles behind it. So generally, that is where it is located. And it's quite protected because of its important function. A lot of blood flows through it. I mean, it's estimated that probably the whole blood flows through it about 30 to 40 times a day, and because of its work as a filtering, organ. So it's quite a delicate organ, well protected in the abdomen, but of course can solve a lot of diseases as we go on. Thank you.
Prof. Che. So I'll go over to Dr. Boima. So Prof. Che has talked about what the kidney is and where it is located in the body. The question is, what do the kidneys do? He said there are two bean-shaped organs. What do they do? I mean, how vital are they to our health?
Okay, so thank you, Prof. Lai, for the question. The kidneys contain, each of the kidneys contain at least 1 million functioning units, and these functioning units serve a lot of functions which are vital for the survival of the human body or the normal functioning of the human body. They are involved in removing waste and toxins from the body. So they remove metabolic waste from the food we eat, etc. The breakdown metabolic products are removed by the kidney. They are also involved in regulating the amount of water in the body, so making sure these solutes or this water and everything remains in the normal balance that ensure the normal functioning of the body. They are involved in regulating electrolyte and minerals as well. So electrolytes such as potassium, sodium, and keeping them in the normal balance as well for normal body function, regulating calcium and phosphate as well to keep them in a normal balance, also for normal body function in terms of your nerves, your muscles, your tissues to function well. These things need to remain in some kind of equilibrium, some form of balance, and the kidney ensures that these things remain in that kind of balance. In addition to, apart with the balancing or let's say regulating of the salt and the water, that is the water and the sodium, they help to control your blood pressure by doing that, and they help to produce other chemical substances, vitamin D, for instance, which helps to absorb calcium from your intestines back into the body, so then it helps to give you strong bones, let's say literally so. And then in addition, they produce hormones or other chemical substances which helps to produce your blood. So your blood also, production of your blood literally is mediated by this hormone or chemical substance which the kidney produces. So in a nutshell, the kidney is really very vital in terms of the normal functioning of the body. Let's say apart from all the other things it's produced, you can say the kidney is the Zoom lion of the body, clearing the toxins and everything from the system.
I love that. So from what you said, the kidney ensures that there is balance. And like you said, it makes sure that it gets rid of the toxins in the body. Right. So my next question is for Prof. Che, but since he's not here, I'm sure you would help me with that, Dr. Brahma. Usually you'd hear, well, for me, the commonest kidney abnormality I've heard of is kidney failure. So my question is, what are the important, because I can imagine there are so many abnormalities, but what are the important ones we need to know about?
Okay, so there are various kidney abnormalities. We can discuss that from the point of the impairment of the kidney function itself, where we look at a chronic kidney disease, which is a condition which maybe had been lingering on for a long time, let's say more than 3 months and beyond. An acute kidney injury, which occurs within a short time and tends to drop the kidney function very fast, and that can also recover as long as the underlying causes are treated. There are other forms of kidney abnormalities, which maybe some people, for instance, tend to leak protein in their urine and get swollen. That is called nephrotic syndrome. That's another kind of abnormality that kidney can suffer. And there are other things like kidney cancers, kidney stones, congenital kidney abnormalities, inherited kidney diseases, amongst others.
Okay, thank you so much. It looks like, if we really want to cover the whole spectrum of kidney disease. We will not. It will take us a year to go through. So thank you. So let's kind of switch a little bit. So you mentioned all these kidney abnormalities. Are these kind of more common in certain like groups, such as maybe males more than females, or in certain parts of the world, or in certain ethnic groups?
So yes, there is a slight male preponderance, slightly more in males compared to females in either in developed or developing countries. That has been the case. Slightly more in males and then also than females when it comes to chronic kidney disease, for instance. And then whether it occurs in other racial group compared to more in other racial compared to the other racial groups, yes, it's true. It's said to occur more commonly among blacks, and they have been. It's been estimated that at least 3 to 4 times common in blacks compared to other racial groups. And this has been attributed to a number of things. Even for instance, the common causes of this chronic kidney disease, for instance, is more prevalent actually probably in the black population, if I'm not lying, maybe hypertension, diabetes, etc. Or maybe it's rising in incidence in our part of the world, which probably is also contributing to the burden of kidney disease. Aside that, there are genetic predispositions. Some genes have been isolated, and the current one is the APOL1 gene, which was found initially among African Americans and thought to be the main predisposition to kidney disease among blacks, but however, among African Americans. But however, this has now been shown to be also very common in blacks who live in Africa, especially in sub-Saharan Africa, where we live. These genes have been shown to be in high frequency and have been shown to predispose to chronic kidney disease, the nephrotic syndrome I mentioned, HIV-associated kidney disease, and other non-diabetic kidney disease have also been shown to be predisposed to by this APOL1 gene polymorphism. And it's been shown that the high-risk alleles or the high-risk variants of this gene are in high frequency in sub-Saharan Africa. So for these reasons, it seems to be more common in our part of the world compared to the other racial groups.
Thank you, Dr. Brahma. Now, whilst we are talking, you kept making reference to kidney disease, kidney impairment, kidney dysfunction, and these words just kept coming in your in what you were saying. Now, so I'm going to ask you a question based on that. What do you mean by kidney disease? What do you mean by kidney dysfunction? What do you mean by kidney impairment?
So we talked about some functions of the kidney earlier on. Now, if the kidney ceases to or stop saving some of the functions that we mentioned earlier on, it means that its function is being impaired. So that's the impaired kidney function that we are referring to. So for instance, the person starts retaining fluid, the person is no longer able to excrete the toxins very well, there are electrolyte abnormalities because the person is not regulating that very well as the kidneys are diseased, etc. Those are signs that the person's kidney function is impaired. So that's the kidney impairment or kidney dysfunction I was referring to. Kidney disease is just a disease of the kidney, and it could be any disease, and it could refer to any of the abnormalities I mentioned earlier on, which may include the chronic kidney disease, the acute kidney injury, nephrotic syndrome, where patients tend to leak a lot of protein in the urine, kidney cancer, congenital kidney diseases. I'm sure Dr. Prof. Chase here, he would add more to the kidney abnormalities now since he dropped off earlier on. So.
Thank you very much. Yes. So, I mean, because you are nephrology, look at it from the nephrology point of view. But of course, as surgeons also, then we have to come in with the other aspects. You mentioned the cancers, that is one area. injuries, we call it trauma. I mean, gunshot injuries, stab wounds to the back or to the abdomen, all this can affect the kidney. So we come in and look at them as well. You also have congenital abnormalities, as he mentioned, absence of a kidney, blockage of a ureter. The ureters connect the kidney to the bladder. So if there are any challenges with the ureter or the bladder, it also reflects on the kidney. So any obstruction down there could also be a reason why the kidney may have a challenge. And of course, we also talk about the stones, which also forms in the kidney. So generally, these are the other additional ones that comes in, and sometimes the surgeon has to come in to be able to help deal with them.
Right. Thank you very much, Prof, and welcome back. Dr. Burma, so can you briefly talk us through the stages of the kidney disease?
Okay, so let me say that the kidney disease or kidney dysfunction, let's literally say there are two of them now, or the two kinds of injury the kidney can suffer. Either it's an acute kidney injury or a chronic kidney disease. Acute kidney injury is a temporary loss of kidney function which occurs in less than 3 months. And the kidney function tends to drop more rapidly in these people due to many causes, such as infections, diarrhea, vomiting, acute heart diseases, burns, trauma, etc. And once the underlying problems are corrected or treated, the acute kidney injury tends to resolve in most of these patients. It's only very few patients with acute kidney injury who may progress to end-stage kidney disease, which I'll talk about when I'm staging the CKD. So largely, most of the acute kidney injuries would recover. However, it's worth noting that an acute kidney injury is a risk factor for developing chronic kidney disease in future. So even though they may recover, they have to be monitored or monitoring their kidney function for the rest of their life. That's very, very important for them to take note of. Now, so apart from the acute kidney injury, we have the chronic kidney disease, which is the injury has link in which the injury lingers on for more than 3 months and then 2 years, etc. So this one is a very slow progressive process, and eventually will progress to end stage. There are 5 stages: stages 1, 2, 3, 4, and up to 5. The 5 is when the kidney function is less than 15. That's the end stage that I was referring to earlier on. So yes, there are various stages. And if I mention that the kidney has at least 1 million functional units earlier on, and as you progressively lose this functional unit, you can progress through all these stages of kidney CKD until you get to the end stage where you may need other forms of treatment.
Thank you. So kind of moving on. So you talked about kind of kidney impairment, kidney dysfunction, chronic kidney disease. Can we talk a little bit in detail about what can damage the kidney, right? So what conditions can affect the kidney from whether it's acute or chronic? I know you mentioned some of the acute causes, but let's talk about some of the important causes that can lead to, kidney damage.
Okay, so we mentioned some causes of acute kidney injury earlier on as when you lose volume by maybe from diarrhea, from vomiting, from blood loss, bleeding from trauma or from surgery, or heart failure, maybe drugs that you may have taken in that can affect the kidney function also acutely. Maybe blockage in the tubes or ureters that Prof. J talked about earlier on can also cause acute kidney injury. The blockage may be from prostate problem, from stones, from blood clot, or any other thing, or stricture, which you may comment on. And all these, if resolved on time, the kidney function may be reversed. And in chronic kidney disease, largely, there are known causes which can start worldwide. The number one cause is likely diabetes worldwide, followed by hypertension, glomerulonephritis, which is an inflammation in the kidney. And then there are inherited causes as well, which is referred to as the polycystic kidney disease, aside other forms of inherited kidney diseases. Then in addition, there are infections, hepatitis B, hepatitis C, HIV are predisposing factors to chronic kidney disease. And then there are other autoimmune diseases like lupus, rheumatoid arthritis, Sjogren's. In fact, lupus can actually cause acute as well. I didn't mention it earlier on. And then in addition to that, environmental exposures, so toxins from the environment, maybe use of NSAIDs, or let's say drugs, painkillers, like brufen, diclofenac, norclofen, naproxen. All these drugs, prolonged exposure may potentially predispose the kidney to damage. In our environment, there has been some associations with chronic kidney disease and the use of herbal medications. So this is yet another possible source of injury to the kidney in the long term, which we need to be aware of. And there are other causes as well. Yeah.
So just to follow up on that question, Prof. Che, do you want to add anything to this in terms of the types of kidney problems that you see as a surgeon?
Yeah. So always, for us as surgeons, we always want to look at the kidney more like, I would say, like the typical water closet we're familiar with. So for the kidney to work well, fluid must flow into it. And so for us as surgeons, anything at all that causes us to lose fluid could prevent the kidney from being able to filter and flush things down, can lead to a kidney problem in the long run. The reason is that the blood that flows to the kidney not only brings in the waste products, but it also brings along the oxygen and the nutrients that the kidneys need. So anything that affects us to lose a lot of fluid can affect the kidney. We'll call it pre-renal, as the clinicians also call it. So that if you have any injury that makes you lose blood, whether you're bleeding in the rectal area, whether you are vomiting blood, whether it is a road traffic accident that you've lost blood, then this can lead to a low pressure and can affect the kidneys. Vomiting, diarrhea, heat waves, this cannot be a reason why somebody may lose so much fluid that blood is not flowing to the kidney, and so the kidney doesn't get its portion of nutrients and oxygen that it needs. And this will lead to what we call acute kidney injuries or ischemic type of injuries to the kidney. So for us as surgeons, we are careful about that. Then the vessel itself that goes to the kidneys, and we talk about the renal arteries. Sometimes they get disease, and then they get enlarged, what we call aneurysms, that forms clots, or they get stenosis or get so small or blocked, and so blood is not flowing to the kidney. We normally call it the vascular problem. So when the kidney has got, the blood supply has got challenges with it, then that can also lead to a kidney injury because they can't get the nutrients and the oxygen that they need. Then, of course, the kidney problems, Dr. Boema, from the nephrology point of view, has mentioned them. Then the obstructions also comes to the purview of the surgeons. Sometimes they are acute. Somebody does a surgery and in the process tie the tubes, and that can lead to a kidney injury. Sometimes because of a long-standing cancer or a particular growth, that can also prevent the kidneys from working effectively. Of course, I also talk about the trauma, the gunshot, the traffic accident, and other things that can damage the kidney. The reality is that from a surgical point of view, apart from the bleeding cases and then the hypovolemia, most of the things happen to one kidney. So if you've got two kidneys, you are likely to survive it. But if per adventure you have only one kidney, which records indicate that probably 1 in 500 to 1 in 1,000 people have only one, then a single damage to a kidney may lead to a loss of function that can be life-threatening as well. So that is where the surgeons look at things, including, of course, the stones that can also block the whole system and either cause a blockage to the urine flowing down. And so pressures build up and destroy the kidney, or it can lead you to get infections, nephritis, renal abscess, and other things that can ultimately destroy the kidney as the kidney has to repair. So that is how the surgeons will also look at the kidney, and we look at it. Thank you.
Thanks, Prof. Che. Now, I was just wondering, as you were talking, and Dr. Boema was talking as well, you did talk about diabetes, you talked about injuries, you talked about trauma, but you never mentioned anything about evil spirit. So my question to you is, where do evil spirits come in the cause of kidney disease? Do they come in at all?
Let Professor Chase start. He is the Reverend Minister.
Please do.
So thank you very much. Now, from the spiritual point of view, I mean, diseases can be caused by the devil. I mean, Father is the origin of the diseases anyway, because God created a perfect world. So diseases, yes, can originate from the devil's camp. And for us as physicians, when we are much more inclined to scientific evidence, one thing we know is that one person gets one disease and recovers, another person is struggling to cover. And sometimes we need a miracle, to be able to achieve. People we thought could not make it have made it. And people we went to sleep and thought that you are fine. The next day realize that we are all struggling for their lives, or we are all struggling to keep them alive. So we won't say that evil spirits, naturally appear. If you appear to the hospital, we will accuse you of a witch or a wizard being the cause of it. But definitely, prayer can make the work of the scientist or the physician much more efficient than normally it would have been. So I've not diagnosed somebody for an evil spirit as being the reason for his kidney cancer. But I would definitely encourage you to pray, because the surgery itself can be risky. The outcomes can be risky. Sometimes even to get the funds to go to the next stage, it takes the grace of God. So we won't discard the spiritual aspect. It's a whole package that we need to move on. That's what I would say.
I love.
Maybe just to add to it, that our perceptions regarding disease from this part of the world is very much influenced by our background, our culture, our tradition. Just like Reverend Prof. Chase said, we are very spiritual beings. Definitely, once the things are not working, we will think it's the devil. Of course, some of this definitely, just like he said, may be true. Others may not be true. We probably be misleading ourselves. There were very few cases on the world where patients will tell you there's somebody who has confessed in my hometown that this is the cause of this problem, so discharge my patient, we're taking him home for healing. And I encountered the first one actually when I was doing my surgical rotation as a medical student, where somebody had a breast cancer on admission, and then they said they should discharge the patient because somebody has confessed in the house that is the cause of the problem, so they want to take the patient home. I thought that was the end, but when I became a doctor, somebody came with nephrotic syndrome. The same thing happened. It says that somebody has confessed in the village that is the cause of the problem, so they'll take the patient home for healing. And we see a few of these every now and then. But I would say that, look, we are spiritual beings. We believe in God. We go to church. We serve God. And we believe that God can heal us. But there's a difference between seeking the miracle and using the solution that God has given us. I believe there are solutions that God has given us all around us. Even the drugs that were extracted from the herbs for us to use now, they were already there. Scientists went to find it, and we are using it now. So I think that if you make use of what the solution is around you, then you have time and you stay alive to look for the miracle. But when you refuse to use the solutions to stay alive and you are dead, you can't even access the miracle. So I think that will encourage people, yes, pray, but at the same time seek treatment from experts.
Awesome. I love that. So viewers, yeah, I just love the way they both tackled this. So like they are saying, these are medical doctors, but guess what? They are also Christians. And so like they rightly said, they do believe in the power of prayer. They do believe in the prophetics and everything. But please don't discharge yourself and go home in the name of seeking a miracle. Stay in the hospital and let the prayers still be done. And it can still work in the hospital, I believe. Whilst you are still on admission, the prayers can still work. Right. So following up, Dr. Boma, what are the symptoms of kidney disease or kidney dysfunction? How do they manifest themselves?
Okay, so let me start. I think the most obvious one, which probably is of concern to most people with a chronic kidney disease, which I think is very important for us to discuss how it presents. Now, the thing is that largely chronic kidney disease is very silent. From stages 1 to 3, you are not feeling anything at all. You look normal like everybody else walking out there in the street without knowing that you have a kidney disease. That's very, very important for you to know. In fact, sometimes if you have to stage 4, you may not feel anything at all. So you don't really have to say, oh, I'm well, I don't have any problem, so why am I being bothered, etc., and therefore I don't need to go to the hospital, which is the song that most people sing here in Ghana. Oh, etc., that kind of thing. I think that must change, because largely this disease is silent. By the time you start having or feeling the symptoms, then it's in advanced stages of the disease. So some of the things that you may feel, maybe, or you may see, is probably early morning, you wake up, you see swelling around your eyelids or facial puffiness. You may see swelling of your feet. But maybe before then, you probably would notice that your urine had become foamy, etc. That these are things that you may notice. But when it's advanced, then you start feeling the fatigue, the tiredness, the breathlessness, the unwellness, the confusion, the abdominal pain, the skin itching, the loss of appetite, etc. All these things come in a very advanced stages of the disease. They don't really manifest in the early stages. So that's why it is important for you to screen for this disease when you know you are in a high risk group. When you know you are predisposed to getting this thing, you don't have to sit down for symptoms. It may just be too late at the time you are presenting. So it's important for you to take note of that.
Thank you so much. So, Prof. Shea, so we've talked about kidney function, and I think the last statement Dr. Boyman made was about screening for the kidney function. So how do we test a person's kidney function? Like, what shows that the kidney is working well or not working well? Or let's say someone has a problem and we want to check their kidney function. So how do we check their kidneys?
Okay, good. So from where he started from, I mean, first we will look out for the symptoms. I mean, what are the issues? You know, are you nauseated? Are you vomiting? Are you getting puffy face? These are the things that we will look out for. Is there blood in the urine when you urinate? Are you having pain at your sides or the flank? So these are the things that will trigger us to want to look at the kidney. Then we will examine you again to see whether there's any pain anywhere. If they are pain in the sides, what we call the renal angles, it draws an attention to us. If you can feel a mass or a swelling in the abdomen, we may look at a kidney tumor as a reason. So once these examinations are done, then we come to the investigations. Normally, they are blood studies, they are urine studies, they are what we call imagings. We are familiar with the scans, whether it's ultrasound scan, the CT scan, the MRI, scans. And sometimes we actually do what we call endoscopy, where we take cameras to go and see what is really happening. Sometimes even the laparoscopy to see what is really happening, depending on what you suspect it is. But generally, looking at the renal function, which is probably what is of most interest to us, the blood urea and the electrolyte levels are very, very useful for us. So the creatinine, the urea, and the electrolytes. The reason is that the kidney is supposed to filter these things and maintain them in very good equilibrium in the system. So if these are high in the blood, then it means that the kidney is not being efficient in its ability to filter the blood. So high levels of urea, high levels of creatinine, high levels of potassium is something that could trigger us to know that maybe the renal function is abnormal. We can also go and determine what we call the GFR, which is the glomerular filtration rate, to find out virtually the capacity of the kidney to do the work that it's supposed to do in terms of filtration and in terms of maintaining the stability of the ions in the system. So we either collect urine 24 hours and then measure the concentrations in the blood and the urine and do some calculations on it, or we can do some estimates, what we call the estimated GFR, taking care of your age, your cells, sometimes your body mass and everything else, putting them together to decide what the capacity of the kidney is. It's based on this reservoir, this capacity of the kidneys to clear these things. That's what the grades of the kidney comes in. Now, when it comes to a urine test, it's very important. The urine is supposed to be clear, but there are a lot of things in there. For instance, if you take the urine and there's a lot of protein in it, then you mentioned nephrotic syndrome. I mean, the kidney is becoming too leaky of protein. It can be diagnostic. You may see blood in the urine. It can tell us that there's something going on. Is it a cancer? Is it a glomerulonephritis? It can tell us. Even the nature of the particles in the urine can be able to tell us. If there are crystals in the urine, it can tell us maybe you've got a stone disease that's the cause of the problem. And sometimes we can even analyze the urine for cancer cells, what we call the urine cytology. So the urine can do a lot of things for us. Sometimes the mere concentration of the urine can tell us what is happening. So these are the things that we look for in the urine. And we'll say that probably the urine is one of the most important tests we can even do because it can tell us what is happening in all these diseases. For the imaging comes when we think there is a blockage. So is it a prostate blockage? Is it a ureteric stone, kidney stone? Is it a stricture damage? Is there maybe a fibroid down there which is compressing on the ureters, or some other tumor of the bowel which is infiltrating and blocking the urine flow? These all can be determined by the imaging, either the ultrasound, the CT scan, or the MRI. And sometimes, as I said, we have to do the endoscopy. We take a camera to look to the urethra, ureteroscopy, to look into the bladder, cystoscopy, to look into the ureters, ureteroscopy, or look into the kidneys, renoscopy. And based on what we find, we may be able to intervene and either dilate, either reconstruct, or break stones that may be causing the damage to the kidney. So all these are available to us. On a few occasions, we have to go and do much more complex blood studies to try to understand, especially for genetical issues that can be useful. Now, when it comes to the kidney problem itself, then I think the boy may talk more about it. Kidney biopsy, which is extremely helpful, especially if the damage is primarily kidney. Want to find out what is happening. Is it a nephrotic syndrome? Is it diabetes that is causing it? Is it a drug that you have taken? In that part of the world, a lot of people take about medications that will ultimately destroy the kidney. And all this could be determined when you do a biopsy of the kidney and look at the distribution of what we call inflammatory cells or the healing cells, and that can tell us. So the assessments are based on what we suspect for the history and examination, and then we can apply the appropriate investigation to be able to assess the problem.
Dr. Boyman, do you have anything to add to what Prof. Che has said?
Yeah, I think that was very extensive. Just to note that we use the ultrasound scan for ourselves to determine the kidney sizes, which help us to tell whether it's a chronic kidney disease or acute kidney injury. So if the kidneys are shrunken or small in size, and then that would really be a signal for chronic kidney injury. Or if the appearance of the kidney it has changed from normal, that may also be a sign of a chronic kidney injury. So just to add to what he said, there are very few occasions where we go out about to do CT scan, MRI of the kidneys to find the cause of the kidney damage.
So, so in terms of so everybody has two kidneys, right? With the exception of a few people who only have one. But are you able to distinguish how much function, say, the left kidney has versus the right kidney? And is that important? And are there times where you need to assess that?
Yes, that is very important. You can actually do that through determining using what you call the isotopic GFR. It's a way of determining the kidney function, just like Dr. Che mentioned earlier on, but this is more using radioisotope kind of measurement. And that can tell you the differential function in each kidney. So it can tell you that, for instance, the left kidney is functioning at 55% and the right kidney is functioning at 45%. Now, this is really very important when it comes to kidney donation for transplant, for instance. You would want to leave the one which is, say, 55 functioning more for the donor and take the one which is, say, 45% for the person who is begging for it or who is the recipient. In this case, that is becomes important when you are doing working up somebody or a potential donor for kidney donation in terms of transplantation.
Yeah, well, from the surgical perspective, we are also able to sample the urine that is coming from each kidney to find out the disease processes. So we can, as I said, take a camera into the urethra, into the bladder, and then put tubes into the both ureters. The ureters are coming from, one is from each kidney. So based on the urine that we collect from one kidney, we can also add on to the differential renal scan to decide which we put in. For instance, if one kidney has got the cancer cells in there, or blood is coming from there, or infectious, pus or fluid is coming from there, we can tell that probably it is either the left or the right that the pathology is sitting in, and then we can address it.
Awesome. Thank you very much. Right. So from what you said, I was just thinking, for me as a layperson, I cannot tell from my urine, well, other than it being blood, I can't tell if there's potassium in my urine. Neither can I tell if there's protein leaking from my urine. So, with COVID, there's a home testing kit. So there's a lateral flow test that you can do at home. And then based on that, you can read and see that, oh, it's positive or it's negative and it means this. So maybe let me follow up with a PCR. Is there something similar with kidney? Is there a home testing kit that I could just buy from the pharmacy and then maybe test myself every 3 months or once a year to see how healthy my kidney is?
There are kits for testing for protein in the urine, which can be used at home. I don't think these are largely available to us in this part of the world, but they help you to determine the protein that is in your urine. But as Dr. J elaborated earlier on, if protein alone is not the end of determining kidney disease, you need to take it forward from there. So even if you find there's protein in your urine, it is a good start for you now to go and visit your doctor and tell the doctor, I have same protein in my urine using kit A or B, etc. And therefore, I want to take it forward from here and do more investigations in terms of creatinine, GFR, and all the things that he talked about earlier on. Here in our part of the world, because we don't have those smartphone kits, etc., that can be used, we actually encourage our patients who have nephrotic syndrome or are leaking protein in the urine to buy the dipstick. So they buy the dipstick and we teach them how to use the dipstick. It's a very simple way of doing it to test for protein. So they can actually test the protein at home and chart it. So when they come into the clinic, they show us the chart of the protein they are detecting in the urine regularly. And then we use that to monitor them on treatment. So a similar thing could be done, yes, but you may have to do the traditional way that is done in a hospital by using a dipstick and urine bottle to collect the urine, therefore test for it. But like I said, it's simple and patients are able to do it. So we use it here to monitor our patients, but it's not available routinely for people to use as home testing kits. I know out there are smartphone kits for testing for albuminuria, but we don't have it here in our part of the world.
Prof. Lai, are you able to chip in a bit on that? How is it like in the United States?
So, in general, people don't go around checking their kidney function. Now, as he mentioned, for people who already have, kidney disease, who are being monitored, they may use the dipstick that he mentioned or other tests, to monitor their treatment. And so sometimes, patients are taught to check that. And so if it gets to a certain level, that is an alarm should go off so that they can, contact their doctor about it, which may mean that, things are going wrong. And as Dr. Boima said earlier on, sometimes things may be going wrong and you have no symptoms until it's too late. And so for people who are already being monitored, they can check these at home. And then if it gets to a certain level, it may be an alarm should go off and say, hey, I need to contact my doctor about it. But in general, people, don't necessarily go around, testing their kidney function. In general, for example, in the United States, if you have insurance, for example, you're supposed to see, have a wellness visit at least once a year. And during that time, depending on your age, you're going to have, blood work done, and that may hint at a problem. But in general, people, like healthy people, don't It's not something that is done routinely.
Thank you. Prof. Che, do you have anything to say?
No, thank you. I think it's been well covered. As I said, I mean, the dipsticks are useful, but the interpretations can be complicated. And sometimes too, even dietary and medications people are on can cause some of these, things to trigger and create an alarm. So, as I said, I mean, if you are being followed up and you are taught well, it can be useful. But anything you pick, you still need to get your experts, because it could be a medication, it could be a fruit or a vegetable you've taken that may have made all these changes. But they are useful things. For instance, in the surgical field, I mean, if you can pick a few cancer cells from these kind of tests, I mean, to see whether cancers are coming back or they have remained dormant. So they are useful. I mean, the context of well-educated person, yeah. But for those who have produced them, I think they are very useful adjunct to our medical practice.
Amazing. Thank you so much. So moving on. Actually, on Friday, I was listening to someone preach, and I heard a testimony about someone being healed from kidney stones. Now, kidney stones is really common, I believe, because it's one of the common impairments that you hear with regards to kidney. So you hear, oh, someone with kidney stones. What are kidney stones? Prof. Che.
Yeah. Okay, thank you. So the kidney stones are quite like salts, like the hard salt we know, in the urinary system. So the kidney filters this substance, waste products and ions from the bloodstream and pours them through the tubes into the bladder and out. And when these chemicals or salts in the urine become concentrated, sometimes we say they were supersaturated, then they crystallize out and form crystals or salts. Initially, these are little pieces, but they then come together and become big. And then once they become big and causes obstruction to the flow, then we have a bit of pain as the body tries to push them out of its system, because it's familiar with fluid and water. By this time around, there's this little stone appearing and you want to kick it out. And that can give a bit of pain. And if it's complete blockage, it can damage the kidney. So generally, it's because of these ions. You realize that if you drink a bit more water, it keeps the ions afloat, and this doesn't happen. But people who are dehydrated, or if for one reason or the other, the chemicals in the urine are higher. Normally, the calcium, you have got the phosphate, you have got uric acid, which are products of protein. If any of these chemicals are extremely high in the urine concentrated, then they can crystallize out and come together to form this stone that can cause such a severe pain. So it is a normal constituent of the urine that has come out to form a salt instead of being a solution, and then gives you a pain as you like. It's like drinking a glass of water and there's a peanut in there. It virtually chokes on you and say, where did this come from? And so that is how it is. Or having an ice block, a block in an ice water you are drinking, and then the block goes down your throat and virtually chokes you out. So that's what happens in the story kidney stones are concerned. Yeah.
So, Prof. Che, I'll come to you, and I think there's a question on what I mentioned from Jacqueline Baxter Hollins, like saying, so screening for kidney function is not something that is done during the annual check. Actually, that is done during the annual check, and that was what I was referring to, that it is done during the annual check when you have the blood work done, but it's not something that is done at home. So I hope that answers your question. So Prof. Che, so you've talked about what kidney stones are and kind of how they form. So I have kind of a two-pronged question. Okay, one is, how does somebody know that they have a kidney stone? And then secondly, why is it that some people are more prone to kidney stones? Because there are people that you may see who have had several kidney stones and have had either surgery or other procedures for them. So can you address both questions?
Okay. So kidney stones are quite a common disease. I mean, yeah. Because of our lifestyle, set of diet, and the fluids that we take in. So it's quite common. How do you know you've got a kidney stone? There's a vast majority that we don't find any symptoms at all. So they go for normal routine check. maybe pregnancy related, some other reason. And then the scan will say that, oh, there's a stone in your kidney, no matter the ultrasound, and they follow up to assess its presence or not. But some come with complaint. The complaint that is obvious to the patient is pain, and that can be very, very severe pain. The pain depends on where the stone is. If the stone is in the kidney tubules itself, what we call the calyces and the minor calyces and major calyces, they have got a pain that is at the flank and then pierces to the back. Normally, initially it starts as something which is called colic. It comes and goes and comes and goes. But once it gets fixed, then it gives a very constant pain. But if the stone is in the pelvis, when it's trying to find its way out of the kidney into the ureter or the tube, then the pain becomes more like we call it colic. It comes and goes and comes and goes because the kidney system is trying to push the stone out. And so it's a severe kind of pain. Most of them will tell you that it's one of the most severe pains I've encountered. And that is very severe. It's associated with vomiting and feeling nauseated because the nerve that supplies this part of the kidney also supplies the stomach as well and the diaphragm as well. So anytime there is this severe pain, every other organ in the tummy, reacts. So you feel like you are bloated, you feel like vomiting, eventually vomiting, you feel like sweating because the vagus nerve, is being stimulated. Others may also present with pain that is, we call it radiation. So the stone is in the renal pelvis or drop into the ureter. Then they've got pain in the scrotum or pain in the Moon's pubis area or the intrata area or the labia area. So sometimes it's a fair pain. So you may see a patient come and he's holding his testicles of pain and you don't feel anything there, only to realize that the pain is actually a referred pain from a kidney stone or uteric stone. So that is it. Then blood, which is blood in the urine. Other obvious to the person, you can see it. Or sometimes you go to an annual checkup and they said, there's blood in your urine. And so blood in the urine can be a reason to suspect a stone, either microscopic because it's only picked at the microscope and the assessment, or because you can see it. Sometimes you also find a stone because of recurrent infections. You get a urinary tract infection, it's treated. Then 3 months down the line, 4 months down the line, infection comes up again. Then you may suspect a stone. Because sometimes the bacteria hides in the stone. So once you take your antibiotics and the bacteria is cleared from the system, and then you are thinking, okay, then those which are hidden in the stone will then crawl back into the urinary system and establish a new infection. So recurrent urinary tract infections is a reason to suspect that probably there's a stone somewhere which is harboring this. So this hard, meaning these are the symptoms that people can get. Of course, if there's a complete blockage, they can get severe pain, and so they can get infections that can be life, threatening. Why do some people get more stone than the others? The main thing is lifestyle. If you are dehydrated, either because of your geographical location, if you are in a desert environment, in Africa, you are in the, desert areas, you are in the Mediterranean areas where it is very hot, then you are prone to it. In some part of African continent where you are in the, close to the northern part of, let's say, Ghana and other Nigeria and other places, they are quite warm because of their closeness to the Sahara Desert, and they can also form stones. You can also form stones because of a blockage in the urinary system itself. So you've got the prostate, you have got a problem with the tubes, and then that can also lead you to form a stone. Sometimes you also form a stone because of an infection. So you've got a urinary tract infection that changes the nature of the urine in the system, and therefore the urine becomes either alkaline or acidic. Normally it's the alkaline. And why the urine becomes alkaline? Normally the urine is acidic. When it becomes alkaline, so all these chemicals will filter out, and then you can form a stone. We also talk about the fact that the stones can be from calcium, it can be from uric acid and other things. So this is metabolized from food. So too much protein, too much chocolate, too much of some vegetables like spinach and other things can give you stones. And so this can also be a reason. And of course, sometimes you're also born with your inability to process these things to their full function. So some people have got what called gout, some people have got high uric acid because they are not able to mobilize or metabolize the proteins to their final soluble form that can be excreted. So these are the reasons. So it's either you are genetically born with it, but most of the time it's environmental. Your drinking habits, your geographical location, or there's a blockage in the system that's not making the urine flow out, and therefore crystallization happens, above wherever the blockage is. So there are various causes, and so that's what makes it quite a common disease across the world. Yeah.
Fantastic. Thank you, Prof. Che. Now, my next question is, right, let's talk about some solutions. So how do you manage kidney stones? And then secondly, do you always have to undergo any treatment, or can they resolve on, like, if you give it a matter of time? Let's say I'm not drinking enough and then suddenly I start drinking loads and loads of water. Would it reverse and then the kidney stones will just go away, or do I have to undergo any form of treatment?
Okay, thank you. So far as the kidney stones are concerned, the first thing we ask ourselves is, as you rightly said, does the kidney stones need treatment or not? If it's not giving you symptoms, pain, blood in the urine, recurrent infections, a fever, we may opt or elect to watch the stone. Especially if the stone is small, less than 5 millimeters, we may just watch. As one of my professors would say, it's not every stone that we treat. So we can just decide to watch it. If it's not giving you pain and it's quite small, we can just watch it. And the evidence that if you drink a bit more water than usual, so you can pass at least 2 liters, 2.5 liters of urine a day, sometimes the stone virtually disappears, virtually dissolves its way away, or it doesn't get any bigger. But if the stone is more than 5 millimeters, then it becomes a problem. Most of the time, it's not likely to drop off, and then it may block the system. So if you realize that you have got pain and the ultrasound shows that it's blocking the system, what they call hydronephrosis or hydrochalasis, then we need to deal with them. Otherwise, they may destroy the kidney ultimately. So then we need to deal with them. Now, you talk about the person who went to church and the stone, was healed. We know that stones can pass spontaneously. As well, if it's less than 5 millimeters or even as much as 7 millimeters, they can pass. What we know is that the lower they are down the tubular system, the more likely they'll pass. So if they're in the distal ureters or mid-ureter, they're likely to pass. But yes, the stone may be in the calyces and they may drop off with time as we drink a lot of water and then as they are so small. So yes, conservatively, they can pass. We have also learned that there are smooth muscles in the tubes that houses these stones. And sometimes if you're able to relax these muscles, the stones could drop off. So we have got some medications to give. Some of the medications we use to treat prostate enlargement, the alpha-adrenergic blockers, can be very effective. So tamsulosin, afizozin, whatever they are, we can give them to relax the smooth muscles, and then the stones will be able to draw by themselves. If they are less than 5 millimeters, definitely. If they are less than 7 millimeters, probably we can. But if the stones are bigger than 7 millimeters, so they are approaching 1 centimeter or 2 centimeters, then we need surgery to deal with them. So how do we deal with them? We have probably 3 main options. The first option is what we call the extracorporeal lithotripsy or method. So what do? We just bring wave forms to hit this stone behind there. For those who have a bit of science, you know about the resonance, that when you put something within the wave pathway of a particular thing that is vibrating, you can cause whatever is in that wavelength to vibrate in unison. And so we cause these stones to vibrate in unison with a source of vibration. And because these are little crystals that have come together to form like a cramp, they can easily disintegrate into these little particles and they are washed away as you drink water. So the extracorporeal shock wave lithotripsy can be effective. Normally for stones that are less than 1 centimeter, we may consider that and it can work. The only caveat is that there must not be any obstruction this time, because if you break these little stones and they get to an obstruction, then each of these little particles then becomes a nidus, becomes its own, galaxy to form another stone. So we must make sure that there are no obstructions and then this can work. So that's the extracorporeal shockwave lithotripsy. If you are pregnant or you've got a tendency to bleed, we may not do this thing because it's contraindicated, because they are high frequency sound waves. And we don't know what will happen to the baby's hearing, and we don't know what will happen. Sometimes it can cause fractures within the kidneys. You might bleed, and that can be a difficulty for us. So that is one way of dealing with it. The other way is a minimally invasive thing. As I said, we can take a camera to look through the ureters, the tube, and all the way up. And once we see the stone either in the ureters or the kidney, then we can use a vibrating something to try and crush the stone. So we can use a vibrator, what they call pneumatic. We can use a laser, which is now very much common now, that we use what we call laser lithotripsy. And the laser is very versatile because you can have a very thick laser stem, and you can have a very flexible one, which you can move around and coil around to break the stone. So we call it the endoscopic treatment of stones, and it's one of the mainstays across the world, which is also available in most of African countries. The next option is to puncture into the kidney. Sometimes we make a direct puncture into the kidney to try and get the stone out, especially if the stone is bigger than 1 centimeter. Because if from too many little particles, sometimes it's difficult to get them to wash down. So we may puncture into the kidney area, and they use any of these forms, the laser, the ultrasound, and crush these stones and then suck them out or pick them out. And so what's called percutaneous nephrolectomy can also be very effective in dealing with this. However, if the stone is very big or there's an obstruction that needs to be dealt with, then we may pick an open surgery to go to do that. You open into a ureter and pick it up, or open into a kidney and pick it up. So despite the extracorporeal lithotripsy, despite the endoscopic treatment, sometimes because of a concomitant problem, we need to do an open surgery and solve the problem and then pick the stone out, especially if there's a diverticular or something. This can be by open surgery or by laparoscopic surgery or by robotic surgery, depending on the facility that's available. In our Africa context, we do more likely to be an open surgery or a laparoscopic surgery. The last point I want to make was the question as to whether people form stones. Yes, the reality is that almost 50% of people who form stones will form the stone again. So one of the things we say that once you form a stone, we call you a stone former, and we have to follow you up, virtually for the rest of your life. So if you form a stone, it's always a risk factor to form a stone, because maybe your occupation still remains the occupation that you are engaged in. Either you are sedentary in the office or you are out there on the field in the heat, and so you are likely to form it again. If the genetic abnormality that causes you not to break down the chemicals to the soluble forms, you still have it in your genetics, so it's going to happen again. So once you form a stone, you are going to form again. But what we know is that one of the most efficient ways or effective ways of preventing yourself from forming a stone is to drink a lot of water. And so if you're a stone former, then the bottle of water should be your friend, and then you'll be okay. But once you form a stone, the chances that you form a stone is between 30 to 50% in a 5 to 10 years time. So you have to take note.
Thank you so much. So we'll move on to Dr. Boima. So now we've talked about solutions to kidney stones. And previously talked a lot about kidney impairment, chronic kidney disease, acute kidney failure and all that. Can we talk about some solutions? I mean, how is kidney impairment or kidney disease or kidney failure treated?
So thank you, Prof. So let's take the acute first. It's not every stage or degree of acute kidney injury that will need any dialysis or anything of the sort. However, it depends on the cause of the kidney problem. So, for instance, if it's diarrhea, you are losing fluid, you need to replace the fluid. If you are vomiting, you need to replace the fluid. If you're bleeding, you need to replace the blood. If it's an infection, you need to treat the infection. If it's a heart problem, it has to be treated. Liver problem has to be treated. If it's a toxin that is causing the acute kidney injury, that toxin would have to be stopped. Let's say a drug or antibiotic or a dye that is used to do a procedure. All those things may have to be kept, has to be taken to prevent people from getting acute kidney injury from all these things. If it's an obstruction to urine flow, just like Dr. Chase said, you have to relieve the obstruction for the pressure buildup to stop damaging the kidney. So, for instance, a prostate, they would pass a catheter to drain the urine. If a stone, they will remove it, etc., to make sure that the injury or the damage does not continue. Now, some patients would have very severe forms of acute kidney injury that will require acute kidney replacement therapy for a short time. The kidney replacement therapy in this case would be dialysis for a short time. And there are indications for doing that. So the indication, maybe if the person comes, for instance, and is breathless because it's accumulated fluid in the lungs, or maybe if the electrolytes are so high, like potassium being very high, like hyperkalemia, for instance, or the person has accumulated a lot of the toxins and therefore is becoming confused. So encephalopathy, for that matter, or developing other complications like bleeding from gastritis, etc., among others, will be in the and probably under the circumstances, the person's urine output progressively is dropping along the line. The kidney function is getting progressively worse. So these people will receive the kidney replacement therapy or dialysis supportively, waiting for the kidney to to recover from the injury, and then you discontinue the dialysis, and then once they recover, they will not need this dialysis anymore, but will need follow-up because acute kidney injury can potentially, like we said earlier on, be a risk factor for a future chronic kidney disease. Now, if you take that of the chronic kidney disease, that also we staged it from stages 1, 2, 3, 4, and up to 5. In the early stages of chronic kidney disease, you do not need dialysis. What is important is to treat the risk factors to slow down the progression of the kidney disease as much as possible. So you define the person's risk profile. So if the person is diabetic or hypertensive, you need to treat all these risk factors to target by using hypertensive medication or diabetic medication to make sure that these things are treated to target to prevent or slow down their long-term damage to the kidney. Number 2, you manage other associated problems that may be there. If there's a cholesterol problem, you need to manage it. If there's anemia or low hemoglobin because the kidney is not producing the hormone we talked about earlier on, the erythropoietin, you have to treat that one as well. If they have their calcium and phosphate problems, you would have to treat them as those ones as well. And then along the line, maybe they will need other forms of drugs to control their blood pressure because their leg is swollen, so will need water pill to help them pee, maybe so to reduce the swelling, etc. All these things will be done in the early stages before when they progress to end stage. That is when you would need some form of kidney replacement therapy, and that is in the form of either dialysis or kidney transplant. The dialysis, there are literally 2 types, really. The blood type of dialysis, which is the hemodialysis, and the water type of dialysis, which is called the peritoneal dialysis. Largely in Ghana, we have the blood type of dialysis, which is the hemodialysis, and most of the patients come from home to the hospital to receive their treatment. That is called in-center hemodialysis. They come to an institution to receive their treatment. There are other forms where the patients can receive their dialysis at home, which is called a home dialysis. That service is available to only 1 or 2 privileged people in Ghana who can afford, because it's not everybody who can afford that kind of home dialysis treatment. For the peritoneal dialysis, which is really also a very good form of dialysis, what we do literally is to put some form of glucose-laden fluid in your tummy, and this literally sucks out excess fluid and the toxins from your body into your abdominal cavity, and that can be drained out after a certain period. That is also a good form of dialysis, an acceptable form of dialysis, which is largely not available in Ghana. Only 1 or 2 people, again, are doing this because they are able to import these consumables on their own. So we give them this service, and they are also doing very well with that. And so the other one is transplant. I'm sure you talk about transplant. So I don't want to talk about transplant right here, right now, since you will be talking about it later.
So essentially, when you talk about dialysis, you are kind of using a machine, or hemodialysis, you're using a machine that works like the kidney to take away the toxins from the blood, right?
Exactly. So you are using a machine to remove the toxins and then the excess fluid from the person. So the person would actually need to be connected to this machine, and it's connected through what we call vascular access. So some forms of connections through to your body, which will either be what you call tubes or catheters into your vein, which connects you to the machine, or what we call fistula, where your vein and your artery are connected to create some kind of pressure for you to be able to connect yourself or to be connected to the machine as well. And the blood flows through this machine or through a filter connected to the machine for over at least 4 hours for you while you are lying there for your blood to be washed this way by removal of the toxins and excess fluid.
So for the peritoneal dialysis, So they do it at home, as you said, and so they put the fluid in the abdomen and it sucks the toxins and then they drain it. So how long does that take? Does
Yes.
that take 4 hours too, like the hemodialysis?
So ideally, the dwell time is about 4 hours, but it depends on the prescription based on the person's needs, for instance. So if the consultant or let's say the doctor reviews and thinks that, oh, you need 4 to 6 hourly exchanges based on your parameters, they can do that as well. So it's even though it's 4 hour dwell time, it's not limited to that. It can be changed based on the prescription given by the kidney disease specialist. For those who are acutely ill, very ill, and come to the hospital, it can be as short as 2 hours, depending on the kind of fluid you are using to suck out those excess fluid and toxins as quickly as possible.
Okay, so in Ghana, for example, how much does dialysis cost, right? And who bears the cost of that? Does insurance pay for it?
So yes, so this is looking at private sector versus public sector in terms of cost. In public sector, largely is between 325 to about 400 Ghana cedis per session, and this is way below $100 per session per session for dialysis. So let's say probably roughly on average about $60 or so, which is really the cost per session. So if you are doing 3 times a week, that is times three. Those who are doing two, that is times two per week. And this is a long-term treatment. So you're going to be paying this for the rest of your life, or unless you get a kidney transplant. At the private sector, the cost can go as high as 450, sometimes 500. So again, even the 500, 450 is still below $100, if you can, as you can see, because the exchange rate is now about 6.01 or 6 point something, if I'm correct. So that's still a little below $100, and even as cheap as it is really very expensive for the large number of people who suffer this illness, because a lot of them who are very young, between the ages of 20 to 50 years. In fact, most of our patients are between the ages of 20 to 50 years, which really compared to outside where most of them are 60 years and above. Here, a lot of people afflicted by the kidney disease are really very young, this age group, and they are unfortunately in the low socioeconomic class. So even this less than $100 is really expensive for most of them, and a large chunk of them are unable to afford this kind of treatment. Only those who can afford are really in the minority. For those who pay, let's say where the money is coming from, largely from it's out of pocket payment. So there is the renal replacement therapy is not on that. It's not on national health insurance, and therefore individuals bear the cost of this treatment. So either the individual is paying himself, or is supported by a family member, or supported by his or her workplace organization, or church, or philanthropist. And I must take this opportunity to say that in my center in Kolabu, there is a philanthropist who is paying for dialysis 2 sessions a week for almost 300 people, and he has been doing this for the past 4 or 5 years, which is really amazing. And we thank him for the work that he's doing, because he's saving a lot of lives from what he's already doing. But a lot of these people would not have had the privilege of treatment had it not been for the fact that he came to help them, and he is still doing it as of now. And we are grateful to him for what he is doing.
Wow, wow. Thank you. Thank you so much. So I have a question for you, Prof. Che, and then I'll come back to you, Dr. Burma. Prof. Che, so my question is, you know, when you're talking about the kidney stones and things, I was just wondering, what determines the size of the kidney stones? What determines how big the stone would be? Right. Prof, You're on mute. It looks like you're on mute because we can't hear you.
Yeah.
It may be a network issue.
Yeah.
Okay. Maybe, do you think you can log off and log back in? Yeah. Okay. So maybe we can move on to the question for Dr. whilst we wait.
Yeah, and Dr. Bama, thanks so much for sharing extensively about dialysis. I had a few questions, but I'm so glad you just answered it along the line, because I was just wondering, actually, how long is it for? And you said it rightly so, that maybe you could have three treatments a week, but it's going to be for a lifetime. And I also want to take this opportunity to say thank you to whoever this philanthropist is. It's amazing. I think it's really such a kind thing for someone to do that. Look, I'm just going to pay for dialysis for people, because if not, then I think it's really a sad thing, like you rightly said. So they are not in the position to afford, they can't pay for these treatments. And so this makes sense, because I have seen so many appeals, GoFundMe, and these things out there where people are asking, can you donate money for dialysis? Can you do that for dialysis? But it's all made sense now. So yeah, thanks for sharing. I want to say hello to Dr. Downing for joining us, to Bishop Isaacs. Hello for joining us from South Africa. Hello to Pastor Jacqueline Buster Hollins for joining us from United States. Hello to Pastor Mrs. Bertha Kimini. Thank you for joining us from
Kenya.
Kenya, thank you, Kenya. And James Samo, thank you for joining us. Kabna Fosu, I don't know where you are, but thanks for joining. And yeah, thank you. Right, Prof. Lai, over to you.
Okay, so Prof. Che, let's talk about transplant. So Dr. Boima has talked about dialysis, and talked about hemodialysis and peritoneal dialysis. So what is transplant, and who qualifies for transplant, and is that available, say, in Ghana, for example?
Am I okay now?
Yes.
Yes.
Thank you. So from where Dr. Boima left off, so once the kidneys are the function is quite gone or damaged, unfortunately the kidney is not able to recover itself, and so they have to get this replacement. So the dialysis is one way of doing that, but a much more efficient way is to bring another kidney to replace what is lost. So normally, if the kidney function goes down below what we call stage 4 or stage 5, then we consider transplant. If you decide to give you a kidney at stage 4, we call it a preemptive transplant. What it means is that normally we initiate the dialysis when you get to the stage 5, but then you want to try to put the kidney in before you get a need for a dialysis. Now, this became important because it was observed by researchers that sometimes if you put the kidney in before the person goes on dialysis, that kidney tends to survive longer than when they have been on dialysis before the transplant. So that is being done. Unfortunately, it's difficult to get a kidney. So most of the time, people end up on the dialysis and at stage 5 before then we can consider putting them on a transplant. So once we decide to give you a transplant at stage 5, when you're already on dialysis, then probably we call that the traditional transplantation that we have. Now, the idea of the transplantation is that the kidney is gone. So let's put a kidney back to replace it. We will go to pick a kidney for somebody who already has a kidney or 2 kidneys and therefore can survive on one when it's taken away, and then put it in you to work in you. It is based on the principle that everybody can survive on a kidney. In fact, it's believed that you can even survive on a quarter of a kidney. So once we take one, the other one is not worse off, and so we can put the kidney in there. So we harvest the kidney and then place it in you and connect it back to the tubing system or to the blood to get it supplied. So if you ask who qualifies for transplant, essentially everybody qualifies for transplant once you get to the stage 5 and better still stage 4. Of course, somebody is donating, so you must make sure that that valuable good is not unduly misused. So we make sure that you are fit enough such that no other comorbidities will let you die. In other words, some people may die from already complications of the renal problem, heart attack and congestive cardiac failure. We will not want to put the kidney transplant in because if you die, we've lost it. And so that is an important consideration to make sure that it will serve the purpose for which it's being donated for. If the reason is because of a cancer, we are a bit cautious because some cancers can come back and then you may lose you. So if you have got a cancer, we may not deny you of it or sometimes wait until about 2 years when you are sure that the cancer is not coming back, then we can give it to you. The only cancer that is exempt is skin cancer. But any other cancer, prostate or kidney cancer or bowel cancer, we'll wait till about 2 years before we give you the transplant. And of course, we also want to make sure that you're not somebody who rejects the transplant easily. Some people have got transplant, they've rejected it about 2 or 3 times. We are a bit skeptical because there could be other reasons why you are rejecting it, which scientifically we are not able to assess. So we take all into consideration, but primarily to make sure that this kidney we are giving you will survive and perform a useful function. But ideally, any person who enters the stage 5 should have the transplant because the quality of life is better than having dialysis, other peritoneal dialysis or chemo dialysis.
So, so you mentioned that with transplant, so somebody comes in and donates one of their kidneys, and so then they undergo surgery. You remove one of their kidneys and put it in the person who needs the transplant.
Exactly.
Now, in other parts of the world, such as the United States and probably the UK, they, even though they do some of the living donor dialysis transplantation, there are sometimes where somebody who may be dying from very serious accident, and they may donate their organs, or they have a system where people indicate on their driver's license that in case I die, I want to donate my organs, and so they will kind of remove those organs and transplant them. Is that something that's done in Ghana?
Currently, no. We call that a cadaveric, transplantation. I was privileged to work in Tagamek Hospital in South Africa. It was quite something. In fact, it was one of the major sources of kidneys for transplant, where people want to say hold their baseless and their donors. Unfortunately, in Ghana, we don't have laws that defines brain death and all the the ethical issues that surrounds it. I know a document that they produced. One of our professors was in charge. I've actually had to preview the document and updated it. I think Dr. Boyama and myself were involved in updating it for current practice. Unfortunately, it's yet to be adopted by our Ministry of Health and insurance companies to work with. So the document has been updated. Especially in South Africa, where the laws are much more firm and the rules are available, it can be a very useful thing. Definitely, brain death is something which can be a good source of kidney for transplantation. Yeah. I know whether Labuama want to add a word to it.
Okay, so maybe just to add to what you said so far, we work closely with the urologists here when it comes to transplant. So our work and intersect very much. And we do a lot of the workup in terms of establishing that the donor is suitable. There's a match between the donor and recipient before transplant. So there is a need for us to take a history from who is willing to donate. There's a need for us to examine this person very well. There's a need for us to do a lot of investigations including the blood group to ensure there's a match, and there's a need for us to also do immunology for tissue typing, and to also do other tests to make sure there are no antibodies or soldiers, let's say, or maybe immune cells in the recipient that can destroy the kidney that it will be transplanted, and a lot of other tests that we carry out, including imaging studies to ensure the donor is healthy himself, and kidneys are functioning very well, and there are no other diseases. Just like he said before, the donor is allowed to donate. Even after this, like you already know, it has to be emotionally motivated or altruistic. It doesn't have to be financially motivated. You don't have to incentivize anybody because it's unethical to do that. So the workup and everything that we do still goes through ethics committee for the ethical committee to now determine the ethics of the transplant. So the bus actually stops in the ethics committee. If they think that this is not altruistic, this is unethical, they can really stop the transplant from going on. And of course, after transplant, there is a post-transplant follow-up. So the patient will be on drugs, powerful anti-rejection drugs or immunosuppressants that keeps the kidney from rejecting in a very long time, which is really also a very, very important stage. Because if you receive the kidney and you don't take your drugs, you're going to reject and lose the kidney. And that's a wasted effort. So it's very important for you to ensure that you take your drugs after transplant.
Right. So can I just ask a question? Does it mean that if I choose to donate one of my kidneys, I can go on to live successfully on just one kidney then?
Sorry, I didn't hear your question very well.
So the question is, if let's say I choose to donate a kidney and you've done all the tests and then it's a match, like you rightly said. So if I choose to donate a kidney, can I still continue to live a healthy life with one kidney? Yes.
I think Dr. Che commented on it earlier on that everybody can live on one kidney, and people, in fact, there are people who are born with one kidney and they don't even know until incidentally is found on scan or something, etc. So largely people can live on one kidney. It is known that when there is an nephrectomy, one of the kidneys is removed, the other one begins to compensate, hyperfunction or maybe hypertrophy, to compensate for the other lost kidney. However, very little has been found in terms of side effects or complications or problems to donors. Very, very rarely there was hypertension has been reported. Very, very rarely blood in the urine has been reported. But there was a 20-year study, meta-analysis, which shows that largely kidney donation is very safe and it shouldn't be a problem.
Thank you. Prof. Lai.
Okay, so we are almost coming to the end of our time. So I think what we'll, the last question that we will ask is, I mean, what could one do to promote, like, kidney health and prevent kidney disease? So if you want to kind of answer this as your parting words, is there something that an individual can do to promote kidney health and prevent kidney disease? I think we'll start with Dr. Boyama.
Okay, so we can start from primary prevention. You first have to know your risk factors. You need to know whether you're in a high risk group in the first place. So if your parents have hypertension, diabetes, you're predisposed to getting it. And you need to be checking this regularly. So that the diabetes and the hypertension, for instance, can be detected very early and treated to target to prevent the development of the kidney disease. If you have a family history of kidney disease, you should also be checking regularly so that it can be detected very early enough to prevent the progression or the development of the kidney disease. Now, behaviors, environmental exposures, like maybe taking in this analgesic habitually, like we talked about. There are a lot of things in the environment, including the herbal concoctions, the aphrodisiacs, the bitters, the concoctions nowadays, I'm told, don't contain only the herbs. They do contain some of the orthodox medication that we prescribe, especially the analgesics like the NSAIDs, for instance, the diclofenac, ibuprofen, etc., may be found in some of these concoctions. So if you drink this, really you may be increasing your risk of kidney disease in the long term. As you know, some of these things are probably the doses may not even be regulated. You keep drinking and then you increase your risk of developing kidney disease. So staying away from them may be a good thing. Avoiding the unnecessary indiscriminate use of over-the-counter pain pills may be a good thing as well. He said adequate hydration has also been shown to be a good thing, but we are not saying that you go and intoxicate yourself, drink water and get water intoxication. No, you are supposed to hydrate yourself adequately enough. Most literature, if you read, they put that 3 liters per day, but even that 3 liters, it's not only water, it's total daily fluid intake. So that will include water, any sort of water, porridge, soup, beverages, etc. The total amount of fluid that you are taking in is what they are talking about, not only water. So you go and drink 3 liters of fluid and you go and drink another 1 liter of cocoa or soup. That will be too much, I think. And therefore, when they say drink adequately, it's not about only the water per se. Of course, there are other liquids you are taking. So factor everything into what you are drinking or you are taking in, etc. Now, when you develop the kidney disease itself, again, all your risk factors have to be treated. And the whole idea is to delay how fast the kidney progresses to any stage for you to need dialysis or transplant. And therefore, again, it's important for you to regularly check your blood pressure, for you to regularly make sure they are treated to target, diabetes, for you to make sure they are treated to target, avoid all the pain, indiscriminate use of analgesics I mentioned, the herbs, adequate fluid intake, etc. All these things can delay progression to end stage. In terms of diet or things that we eat, from the recommendation, there is what we call protein restriction in the early stages of kidney disease, where the protein is restricted to say between 0.6 to 0.8 grams per kilogram body weight per day. See a dietitian, a professional dietitian, to quantify this for you. This is outside this discussion, so you can see a professional dietitian to quantify this for you that you need to know and also adhere to. Generally, more fruits, more vegetables, fluid intake, etc., will be healthy in terms of BP control, in terms of sugar control, in terms of losing weight to also reduce its effect or risk of kidney disease, decrease alcohol intake or avoid alcohol intake if you can, stop smoking, low salt intake or decreased salt intake less than 2 grams per day are things you could do to prevent or slow the progression of kidney disease.
So maybe I will ask. There are a couple of questions there. So as you guys take this, if you can answer them as you go along. So one is, does cube or monosodium consumption have effect on the kidney? And then the other one is, what dietary advice will you recommend as in foods that enhance good kidney health? I think you mentioned some of them. Prof. Che, you can, as you talk about promoting good kidney health, if you can answer some of the questions, and Dr. Boama can also answer them.
So the monosodium gluconate, yes, there's a scientific evidence showing that it can increase the risk of kidney disease, and therefore it is not advisable to be using monosodium gluconate in our food. We probably don't need it even this in the form of the white cubes, whatever we call them, that people use to cook all kinds of things, etc. It's been shown that it increases the risk of kidney disease, and then therefore not advisable to do that. I have already mentioned the dietary one, so I'm sure Dr. Che has other ideas. So I'll leave it for him to talk about.
Thank you very much. So I think that by and large, Dr. Boyama has dealt with the issues. Yeah. From our surgical point of view, we will say that prostate diseases, especially in African context, need to be treated and treated. I mean, with all the seriousness that is there. Especially the benign prostate hyperplasia, it's just benign. But patients you have lost, a large proportion is due to kidney failure from obstruction, what they call obstructive uropathy. So from a surgical perspective, I would say that it's important that prostate diseases are well treated because they are very important cause of kidney problems, in addition to the diabetes and hypertension that he's talking about. Of course, if there's a stone, I mean, that also needs to be dealt with. Infections also need to be dealt with effectively. So I would say that from the surgical perspective, probably the prostate is something I want to mention, looking at our audience, that there's no cancer, but you need to pay attention to it. Otherwise, it can lead to a kidney damage.
So to clarify, so you're talking about so prostate. So every man has a prostate, and as you get older, your prostate gets bigger, and so it can block urine flow, right?
Okay.
And so that's what you are talking about, right? That if the prostate,
those with clinical symptoms of straining to pass urine or urine free stream, these are the ones that, and they should pay attention.
Yes. So if you're a man and you are, as you get older, you are having difficulty urinating or having a good urinary stream, it's important to be checked about that, because sometimes that type of blockage, the prostate getting bigger can block urine flow, and then the backflow, kind of the dam effect, can damage the kidneys. And so that's what Prof. Che was talking about.
Oh, all too soon. Our time is up, but it's just been another educative session. And all I've been thinking about is really, so it's all about back to the basics. The very first topic we did, Prof. Lai, prevention, knowing your numbers, keeping your BMI in check. If you are at risk, just make sure that you are managing your diabetes, managing your happy, because all these things, some way, somehow, they are all interlinked, they are all interconnected. So the untreated diabetes is eventually going to end up affecting your kidney. The untreated hypertension is going to end up affecting your kidney. And it's just, yeah. So I think, viewers, this is my take-home message. This is what I am personally learning, that look, we cannot overemphasize the importance of keeping ourselves healthy, making sure we are eating right, we are drinking lots of water, and there are so many memes about it. Drink lots of water and mind your own business. So we should make sure we are drinking lots and lots of water. But very important that we eat right, Dr. Brahma was actually emphasizing on fruits, vegetables, and these are all things that we've spoken about over the month, over the last few weeks. We've discussed these things. And because really, if you do these things, then you are avoiding the end state, that is dialysis and having a transplant. If you don't want to get to that point, then what you have to do now, and like we all know, they say prevention is better than cure. Prevention is better than cure. It's better to be safe than to be sorry. So now that you are healthy, this is the time for you to do the right thing. And as a mom, my take-home message is, I'm going to start from my kitchen. I'm going to start in my house, in my kitchen, teaching my children the importance of eating right. I'm not going to wait until, touch wood, you hear the bad news before you suddenly start seeking for a miracle and then do it. Because the miracle itself is in eating right. So if you are eating right now, then hopefully you are doing something right, and then you don't have to eventually go and seek for a miracle. You don't have to be discharged and go to the hospital saying that someone has confessed that she's the cause of that and she's the cause of that. And Prof. Lai, what would you like to just your final message for us, please?
Thank you. I think you have hit the nail on the head, that it's important for us to be prevention minded. And as you said, prevention is better than cure. And there's a saying that a stitch in time saves 9, which means that if you are having a tear in your shed, and you put one stitch in it, that may solve it. It will prevent it from getting larger, so that you need 9 stitches, right? So again, to reiterate the point that I made at the beginning, that our bodies are the temple of the Holy Spirit, as Paul said. And then at some point, Paul said, if we destroy the body, God will destroy us. And so we have a responsibility to make sure that our bodies are in good shape, so that we can fulfill the kingdom mandate that God has given us. I always say this: you cannot fully fulfill your purpose if you are sick all the time. And as Dr. Boima said, can you imagine if you have to be on dialysis 4 hours a day, 3 times a week? I mean, how effective are you going to be? You're going to be hooked up to a machine 4 hours a day for 3 times a week. So what time will you even have to go to work? And then if you have to do some sort of a kingdom assignment, how are you going to be as effective? And so it's important for us to think about these things and not downplay them, because sometimes people think, oh, I'm doing God's work, and so I'm immune from all other things. So you don't sleep, you don't eat right, you don't do all the preventive things. And we've seen people and even some very effective men of God die because they did not pay attention to their health. And so I think it's important for all of us to understand that and to apply this to our lives. Thank you guys once again, and hopefully we will come back your way next month with another topic.
Thank you.
Thank you.
Thank you.